Good morning, all of you. Probably before I start, let me tell you two things. Today, this ECG, we are dealing with the part 2 of the ECG, and this will be your last theory class. And with this, we will be completing all the topics which were allotted and which has been assigned for your batch. Theory topics will be completed. At the end of the session, I would like that you just send a mail to me to my email ID, that is viceprincipal.negi@mims.edu.in, where you just write about the requirement of any revision classes and the topics which you want to be repeated again or to be explained. If not the whole chapter or the whole topic, some subtopics you feel that it has to be discussed again, please send it to me through the mail. We shall work out on that depending upon the number of requests received or emails received. We will have a revision classes. So now after this, from tomorrow, there will be some practical classes taken. In that practicals, you will have only a discussion on the charts and the graphs, which you will be put in the question in the exams. They may be the cardiac graphs or they may be the muscle graphs and some non-endocrine charts. So there are about 6 or 8, I think, non-endocrine charts to be covered. Maybe between some of our faculty or I may take some or two charts and we'll have a discussion on that. So that becomes a division also. This is about the theory classes, online theory classes. And secondly, yesterday we received a MCI advisory, which you I'm sure would have seen in the papers also, that for the first year students, pertaining to the first year students, they have said that whenever the government decides that the colleges have to be started, classes and you have to come back to the college, from that permitted day, within 2 months, we have to finish some practical theory classes and finish off the syllabus, whatever is pending. So within that 2 months, once the practicals and the theories, whatever is left has been completed, your final exam dates will start. So let's say from the date whenever the government and whenever the central government announces the reopening up of the colleges, you will have your board exams. In these 2 months, whenever as per the schedule they are released, we will expect that you come back to the department and there we have to do some practicals. For example, your cardiovascular system is pending, the blood pressure examination is pending, and I think the respiratory system is also needs to be done. We will work out according to the plan, but also utilize this time period of 2 months plus the window period you have. That is, as of now, 1 month is definite that the government has said that no colleges should be open till 31st August. So 2 months plus this 1 month, assuming that these 3 months window period you have, and you start preparing for your exams very seriously. Okay, now let us go back to our ECG part 2. Yesterday I had talked about the definition of the ECG, what is the record, how is the electrical currents being recorded by the electrodes, what are the different leads, the chest leads, unipolar, bipolar leads, and what are the waves in the ECG I had just briefly introduced. Today we start off from there, where there are, if you see the ECG record, you will find that there are 4 positive waves. The P wave, the P wave, the R wave and the T wave are the positive waves there, and you will have 2 negative waves, that is the Q wave and the S wave. So these are the waves, plus in addition to this you will have another T wave, which is a positive wave. So basically P, Q, R, S and T waves are there. These are the 5 waves. In addition to this, there will be a U wave, which is not normally seen. Among this, the positive waves are the waves which are present above the baseline, and they are the P waves, the R waves and the T waves, whereas the negative waves are which is below the baseline, and it is called as it is the Q wave and S wave. So what do you mean by positive wave and what do you mean by a negative wave? A positive wave is a wave where the current is flowing or moving towards the electrode, so it records a positive deflection, and that is seen in the P, R, S and the T waves. Whereas if the current which is coming from the interior to the heart to the surface of the skin and it goes away from the electrode, it gives a negative wave, and there are 2 negative waves, the Q wave and the S wave. Now if you see the whole thing, the whole of the ECG consists of a P wave, a QRS complex and a T wave. So this is how we describe it: a P wave, a QRS complex and a T wave. Now let us individually see what is the cause of the wave. So let us say the first wave. The first wave is the P wave. Now the P wave is the wave which is recorded because of the depolarization taking place in the atria. So the P wave is a record of the atrial depolarization. The P wave is a positive wave. If you see the height of the P wave is somewhere around 0.3 millivolts. The duration of the P wave, that is from the beginning of the P wave to the end of the P wave, the duration of the P wave should be somewhere around 0.1 milliseconds. The P wave is positive in almost all the leads. By almost all the leads we mean that it is positive in lead 1, lead 2, lead 3, and it is also positive in lead 2, lead 3, V2, V3, V4, V5 and V6. That means the P wave is a positive wave in almost all the leads except the AVR and V1. If you find that the P wave is a negative wave in AVR and in V1, it is a normal recording. But in most of the leads you will find that the P wave is a positive wave. Now what does this signify? And another significance you understand here is, if the height of the P wave is increased, that is, I said that the height of the P wave should be 0.3 millivolts. If the height is increased, that means there is more muscle mass, more voltage which is being generated. That means that there is more atrial size. So in height of the P wave becoming increased means that it is atrial hypertrophy. So this is about the P wave. Then next we have the next complex here is the QRS wave. In this QRS complex, Q is a negative wave, R is a positive wave and S is again a negative wave. Here you can see the Q wave, the R wave and the S wave, and it is known as QRS complex. Now the whole duration of the QRS complex, whole duration of this QRS complex is somewhere around 0.1 seconds. The cause of the QRS complex is because of the depolarization of the ventricles. So the cause of the QRS complex is the depolarization of the ventricles, in which the Q wave is because of the depolarization of the mid portion of the interventricular septum. The R and the S portions are because of the depolarization of the basal parts of the ventricular chambers. So whenever there is a depolarization in the ventricles, a QRS complex is being generated, and this depolarization is in Q wave generated because of the interventricular septum. R wave and the S wave is because of the basal portions of the ventricular chambers. Now the duration of this whole of the QRS complex, that is from the beginning of the Q wave to the end of the S wave here, this is the S wave which ends. So this QRS complex is around 0.1 seconds. This Q wave is present in most of the leads, but it is absent in V1, V2 and lead 2. That is a normal phenomena. If you do not find a Q wave in V1, V2 and lead 2, it is normal. Incomplete Q wave in all the leads will indicate myocardial infarction. Okay, so this is about the QRS complex. Next, the T wave. What is the cause of the T wave? The T wave is because of the repolarization of the ventricles. So the cause of the T wave is the repolarization of the ventricles. The T wave duration is somewhere around, the duration of the T wave, that is from the beginning of the T wave to the end of the T wave, the duration is around 0.27 seconds. The height of the T wave is somewhere around 0.3 millivolts, 0.375 millivolts. That is the height of the T wave. Now let us discuss some more things here. Now here we see that this PQRST complex is the electrical recording or the ECG of a single heartbeat. Then this next QRST complex, PQRST wave, is of the next heartbeat. So each heartbeat generates these electrical waves. Now the gap between the two successive R wave is known as the RR interval. So the RR interval between two successive ECG waves signifies the duration of the single cardiac cycle. Also, this can be used in calculating the heart rate. So how do you calculate the heart rate from an ECG? Now to calculate the heart rate from the ECG, you have to know the number of squares between the two RR waves. Now if you calculate the number of squares in the RR between the two successive RR waves, you can know the heart rate. How? Count the number of small squares between the two RR waves and divide it by 1500. That is 1500 divided by the number of small squares between two RR waves will give you the heart rate. Or 300 divided by the number of big squares. Here you see 1, 2, 3, 4, 5. So these the gap between the two RR waves, if you see the number of big squares is 5. 1, this is 2, this is 3, this is 4, this is 5. So 300 divided by number of big squares, that is 5, it gives around 60. So that will be the heart rate of that particular person. So 60 is the heart rate of this particular individual. Now otherwise count the number of small squares between the two RR, and 1500 divided by that will give you the heart rate in the same particular record. So you can calculate the heart rate between the two RR waves. Now some significance in the R wave. Now when you note the R wave and you study the R wave which is present in the different leads, we know that the PQRST wave will be recorded on all the waves. Now suppose if you study the height of the Q wave in the segments in the chest leads, that is from V1 to V6, what you will find that from the V1 to V6 there will be a progressive increase in the R wave, whereas when you move from V1 to V6 in S wave you will find that there is a progressive decrease in the height of the S wave. This is a normal observation seen. Say for example, if you are seeing an ECG and that ECG will contain the records from V1 to V6, and if you compare the R wave, height of the R wave from V1 to V6, you will see that progressively the height of the R wave increases from V1 to V6, whereas the height of the S wave from V1 to V6 progressively decreases. In lead V3, you will find that the height of the R wave and the height of the S wave is nearly equal. So this is a normal finding of an ECG. I am repeating this again. If you study the chest leads, that is the V1, V2, V3, V4, V5, V6, and you observe the QRS waves in the leads progressively from V1 to V6, you will see two observations in a normal ECG. What is the normal observation? The height of the R wave increases from V1 to V6, and progressively the height of the S wave decreases from V1 to V6. In V3, you will find that the height of the R wave and the S wave are nearly equal. This is about the R wave. Another significant thing of the R wave is the R wave height in V5 and V6, the height of the R wave in V5 and V6, and the height of the S wave in V1 and V2 indicates left ventricular activity. So when you are seeing the height or the status or the shape of the R wave in V5 and V6 or the S wave in V1 and V2, this will indicate the record of the left ventricular activity. Whereas similarly, the R wave in V1 and V2 and the S wave in V5 and V6 indicates right ventricular activity. So two observations you have seen: the heights of the R wave and the S wave comparing from V1 to V6, and then the activity of the left atrial and left ventricular and the right ventricular chambers pertaining to the R wave and S wave. So what do you know? The R wave in V5 and V6 and the S wave in V1 and V2 will give information of the left ventricular activity, whereas the R wave in V1 and V2 and the S wave in V5 and V6 will give activity on the right ventricular chamber. Okay, now let us briefly discuss about the pathology here. Now, an increase in the amplitude of R wave, in V1 and V2 and lead 3 indicates right ventricular hypertrophy. I am repeating it. If the height of the R wave is increased in V1 and V2 and in lead 3, it indicates right ventricular activity, hypertrophy. If the amplitude of the R wave is increased in V5 and V6 and lead 1, it indicates left ventricular hypertrophy. Okay, now let us discuss briefly about some segments. So here you will find intervals and segments. First let us discuss about the PR interval. Now if you see the what is PR interval? PR interval is the interval of the wave or the time between the beginning of the P wave to the beginning of the R wave is called as the PR interval. I am repeating it again. PR interval is the interval from the beginning of the P wave to the beginning of R wave is the PR interval. So here it is. The P wave begins here and the R wave is here. So this interval is called as the PR interval. The PR interval normally should be somewhere around 0.1 to 0.12 to 0.16 seconds. An increase in the PR interval indicates conduction blocks or conduction defects. Normally, if you see the diagram here, the P wave and the R wave is the depolarization wave, or the wave which is going from the atria to the ventricles. Normally, this duration from P wave to R wave should be somewhere around to the max about 0.12 seconds. If you remember in the class earlier when I discussed about conduction defects, I had given you the duration of the time for the impulse to travel from the P wave from the atria to the ventricles or from the SA node to the AV node. The same record on the ECG can be seen here, where the duration of the impulse to pass from the beginning of the P wave to the R wave indicates that the time elapsed from the impulse to move from the atria to the ventricles or from the SA node to the AV node, and that should be maximum around 0.12 seconds. If there is an increase in this duration of P wave, that means what it means that there is more time which is required for the impulse to travel from the SA node to the AV node, indicating that there is some conduction defect. So what is first that is called as incomplete heart block. A prolonged interval is incomplete heart block, and this incomplete block is about a first degree block, second degree block. So what do you mean by first degree block? First degree block means an interval, a PR interval of more than 0.16 seconds means that there is a first degree heart block. Now if the increase is beyond 1/6 or 0.2 seconds, what happens is, you should understand that the impulse is coming from the P wave going from the atria to the ventricles, that is from the SA node to the AV node. This duration of transmission is prolonged. So what will happen? This interval will get prolonged. That is a first degree heart block. If it is increasing beyond 2.2 milliseconds, then what will happen? For every 2 waves, you will find that there is 1 R wave, because the atrial activity is going on, the SA node activity is going on, but there is a delay from the SA node to reach to the AV node. So the atria are having depolarization, the ventricles are having depolarization, but this is taking a long time. So by the time the first impulse reaches from the SA node to the AV node, there is another impulse which is generated at the SA node. So that is called as a 2 degree second degree heart block or 2:1 block. That is not second degree heart block, it is a second degree heart block with 2:1. 2 P waves followed by 1 R wave. In 3:1 block, it is known as where there are 3 pre waves followed by 1 QRS complex, so that is known as 3:1 block. All this comes under second degree heart block. And what is a complete heart block? In a complete heart block, the P wave is independent of the QRS complex, so both are irregular, both are not synchronized. That is, not synchronized means a P wave followed by QRS complex is not happening, and that P waves and QRS ratio is more than 3:1 or is irregular, then we call it as a complete heart block. So this is a defect where you will find that the conduction velocity is slowed down, where there is a delay in conduction. There is another condition where you will find that the impulse is traveling very fast, and this transmission of impulse from the SA node to the AV node, or from the atria to the ventricles, is very fast. If it is less than 0.8 seconds, it is called as a Wolff-Parkinson's-White syndrome. Just remember WPW syndrome. This WPW syndrome is because of the faster conduction of the impulse from the SA node to the AV node, or from the atria to the ventricles, and this is because of the presence of an abnormal conducting system or abnormal conducting bundle known as the bundle of Kent. So this is about the WPW syndrome. Now let us see some of these. The other interval is the QT interval. Now what is QT interval? QT interval is the interval which is from the beginning of the Q wave to the end of the T wave is QT interval. The duration of the QT interval is somewhere around 350 milliseconds, or maximum it is 400 milliseconds. It indicates the duration of the QRS complex. An increase in the QT interval indicates a prolonged QRS complex. So a prolonged QRS complex, in other words, means again a delayed conduction. This time the delayed conduction is at the node, at the AV node. Hence there is a long time taken for the impulse to pass from the AV node into the ventricles, and there is a prolonged QT interval. So this QT interval, if it is prolonged, will again cause heart blocks. Yesterday I had told you, that is on Monday I had told you about the importance of chloroquine in this, the hydroxychloroquine. What hydroxychloroquine does is it prolongs the QRS complex. Duration of the QRS complex is prolonged, hence the QT interval is increased. Now there are certain segments. What is segment? This is the PR segment. What is PR segment? PR segment is the segment from the beginning, from the end of the P wave to the beginning of the R wave. This segment is known as the PR segment. So here, from the end of the P wave to the beginning of the R wave, this segment is known as the PR segment. The interval is from the beginning of P wave to the beginning of R wave, but the PR segment is from the P wave, end of the P wave to the beginning of the R wave, is called as the PR segment. Then there is another segment which is known as the ST segment. ST segment is from the end of the S wave to the end of the T wave, is called as ST segment. This ST segment is very important because this ST segment, changes in the ST segment, either elevation of the ST segment or the depression of the ST segment, may indicate infarctions or ischemias. So remember, what is ST segment? ST segment is from the end of the S wave to the end of the T wave, and the duration of these ST segment is somewhere around 0.37 milliseconds or 370 milliseconds. Then the other is the QT interval. I have spoken to you about the QT interval. Now some of the things which we have already discussed, the P wave. The P wave immediately precedes the atrial contraction. The QRS complex immediately precedes the ventricular contraction. This, if we recall the class which we had discussed in the conducting system, we say that first there is an electrical event followed by a mechanical event. So also the P wave occurs, that is the electrical event. Once the electrical event has passed over the atria, it is followed by atrial contraction. Now after the P wave has passed through the atria, it goes into the ventricles, that is through the SA node, through the internodal tracts to the AV node, and from the AV node it spreads into the ventricles. So the electrical complex of that, or the electrical events, are represented in an ECG by a QRS complex. Once the QRS complex is completed, it is followed by the mechanical event, that is the ventricular contractions. The ventricles remain contracted for a few milliseconds after the end of the T wave. So even after the repolarization wave has finished over the ventricles in a mechanical way remain contracted for some time. The atria also remain until the atria repolarize, but we do not see an atrial repolarization wave because the atrial repolarization wave which is there is merged with the QRS complex. So why do we not see the atrial repolarization? The atrial repolarization is not seen because it coincides with the ventricular depolarization and it gets merged. So here I was saying about the thing where I was saying that this is the lead 1, lead 2, lead 3. Here you have PQRS complex in lead 1, PQRS complex in lead 2, PQRS T wave. Here you will see that there is abnormality and it is normal. Similarly, AVR, AVL and AVF, you will find that the absence of A wave, P wave here. Then go on to the V1. This is the PQRST complex. T wave is inverted in V1. I told you T wave may be inverted in Q1 in V1. So here it is inverted. It may also be inverted in AVR. So these are normal. An inverted T wave in V1 and an inverted T wave in AVR are normal. So here you find that these are the QRS waves. You will see they gradually you will find that as you go from V1 to V6, you will find that there is a gradual increase in the height of the R wave and a gradual decrease in the height of the S wave. And here you will find the T wave. This is the ST segment. There is a different. These are all normal records of an ECG. So this is a complete ECG when you see all the waves, the P wave, the QRS wave and the T waves in different leads. When you want to come to a diagnosis, you have to compare all the QRS complexes, P waves and the T waves with respect to the various leads. Now let us see what are the abnormalities. Now abnormalities, sinus tachycardia. It means that sinus means the rhythm or the pacemaker of the heart is the sinus node. It is generating at a rhythm, but the rhythm is higher than normal and it is called as a abnormal sinus rhythm. So when the abnormal sinus rhythm means tachycardia. So tachycardia is nothing but a heart rate which is more than 100, and here you will find that there is the increase in the heart rate. Broadly, if you see, I said if you want to calculate the ECG heart rate, you have to calculate the heart rate between the two RR waves. So here calculate the two RR waves. Here you will find 300. Let us take the big squares. The big squares here are somewhere around 300 divided by nearly 2. So 150 will be the heart rate, or you can count the number of small squares here between the two RR waves and divide it 1500 divided by the number of small squares will give you a heart rate. But in general, to understand whether the heart rate is normal or abnormal, by seeing generally an ECG, you will see that if the number of beats are very close to each other or the RR intervals are very close to each other, you will just broadly get an idea that there is a tachycardia, because the spacing is increased, the RR interval is very less here. So in general, at seeing an ECG without any calculations, you can say that there may be a tachycardia. To know exactly how much is a tachycardia, divided by 300 number of big squares or 1500 by number of small squares. Now we are not going into the details what is the cause of the tachycardia, because we will just restrict to the findings here. Now what is sinus bradycardia? Bradycardia means a decrease in the heart rate. Sinus means SA node is the rhythm. If the SA node is the pacemaker of the heart and it is generating impulses at a at a slower rate, it is known as sinus bradycardia. Now here see the sinus bradycardia. Gradually you will see any wild guess also can say that this person is having a slower heart rate. See the gap between the RR interval, it is so prolonged. So rough estimate can be that there is a slow rate. Now to know exactly how much slow rate it is, you need to calculate the number of big squares between the two R waves. So here you take this. About 6 squares are there. 3, 4, 6. So divide 300 by nearly 6 to 7. You will find that the heart rate has come down to around 20 or 30 per minute. So this is bradycardia. Normally, physiologically, here we'll just add a point here. Bradycardia is commonly seen in athletes who have a large stroke volume. It is because of vagal stimulation, strong vagal stimulation, where there is a less heart rate but the stroke volume is more. So here in general, to compare it, this is a normal sinus rhythm, this is an increase in the heart rate, this is a decrease in the heart rate. See the number of waves here between these two. This is a normal sinus rhythm, so many year waves you will find. So where the RR interval is reduced, that means there is sinus tachycardia. If you find that the RR interval between the two waves is prolonged, that means that there is a bradycardia. What is arrhythmia? Arrhythmia means that variation of the heart rate with the ECG is called as sinus arrhythmia. Variation of the heart rate, with breathing is called as sinus arrhythmia. Heart blocks, I had told you earlier, complete heart block, incomplete heart block. Now see, it is a rare instance where you will find that impulses from the SA node are blocked, so you will find that there is an absence of P wave. So an absence of P wave indicates that there is no SA node generated. One more thing here I wanted to tell you here is absence of Q wave in all the leads indicates a congenital absence of interventricular septum. So if there is an interventricular septum which has not been developed, a congenital absence of that, you find that there is no Q wave in any of the recordings, in any of the ECG recordings from any lead, it indicates absent IVS. Now this is about a sinoatrial block. Here you will find that there is no P wave occurring simultaneously before the QRS complex. So you find that a QRS wave and a T wave is seen. Then what is an atrioventricular block? So atrioventricular block is nothing but impulses from the AV node and the AV bundle are blocked or slowed down. It can be because of the compression of the AV bundle, or there may be ischemia or myocardial infarction which has caused damage to the AV node or the AV bundle, or because of some cardiac inflammation, myocarditis or something. There may be a inflammation of the AV node. So whenever there is either a damage to the AV node or the AV bundle, or there is a compression by any scar tissue, or if there is a inflammation of the bundle, the impulses will not pass freely. So it is a complete heart block and an incomplete heart block. First degree heart block, normally the PR interval is 0.1 second. If it is more than 0.2 seconds, it is a first degree heart block. So this is the diagram which will show prolonged PR interval. Here you see that this is the SA node, this is the AV node, impulses are going down. There is a delay happening here because of some reason. So you will find that this P wave should be very close to the QRS complex, but it is not there. So there is a delay. The P wave is normal, but it is not followed immediately by a QRS impulse. So the QRS wave is taking some time to happen. So that means there is some delay from the atria to the ventricles, and this is reflected by a prolonged PR interval. So here you can see the prolonged PR intervals there. So here you can see that there is a prolonged PR interval. Second degree heart blocks or second degree incomplete heart blocks, you will find that the PR interval is increased from more than 0.2 to 0.4 seconds. Some impulses do not pass, and these that do not pass are known as dropped beats. So here you will find that there is a conduction defect. Here you will find that normally you will see that the P wave should be followed by a QRS complex, but here there is a delay also, the PR interval is prolonged, plus you will find that for every 2 P waves then there is one QRS complex. This is known as 2:1 block. There you will find that there is a drop beat. Third degree heart block is totally there is a dissociation between the atria and the ventricles. There is no hierarchy being followed where P should be followed by a QRS complex. In other words, to simply mean that the P waves the atria are beating independently of the QRS. The atrial contractions, atrial systole and the atrial diastole is separated from the QRS, from the ventricular atrial and the diastole. So here you can see the first degree heart blocks. Here you will just find in the first degree heart block, you will find that there is a prolonged P wave. Here you will find prolonged P wave. So this also gives to a prolonged PR interval. So here there is a prolonged PR interval. Then you will find that for every 2 P waves there is one QRS complex, and in third degree heart blocks there are multiple P waves followed by one QRS, and this pattern is not repeated. So this is the third degree heart block. What is Stokes-Adams syndrome? Stokes-Adams syndrome is a complete AV block. That means there is a total blockage from the AV, from the atrioventricular node. There is no impulses which are going from the SA node into the ventricles. As a result of which, suddenly the ventricles will stop beating for a few seconds, about 5 to 30 seconds, and that is known as because of the overdrive suppression. So suddenly if there is a AV block happening, the ventricles do not receive impulses, so they do not contract for a few seconds, say around half a minute or so. When they are not contracting, they are not pumping out blood, so no blood from the left ventricle into the aorta, no blood into the systemic circulation, so no blood going into the brain, cerebral circulation suddenly drops, and because there is a loss of blood supply, hypoxia, the person faints. So now after a few seconds, no beating of the heart will generate the ventricle will generate its own rhythm, and that is known as a nodal rhythm. It is known as the idioventricular rhythm, and there the heartbeat the heart may beat around 50 to 40 beats per minute. Such person should be connected to pacemakers. Now here it is a prolonged QT interval. This is what I wanted to show you. See, this is the QT interval, beginning of the Q wave to the T wave, end of the T wave is known as the QT segment, or it is also known as the QT interval. Here if you find this normal QT interval should be somewhere around 0.45 seconds, or the ST segment also if you take down here, it should be around 0.35 seconds. But let's concentrate on QT segment from the beginning of the Q wave to the end of the T wave. Here you will find that there is a beginning, there is a prolonged QT interval. See the duration. Now in this pandemic, this is what I was saying, if you give hydroxychloroquine to a patient who is already having some cardiac defect or a conduction defect or a hypertensive defect, where he has been put on drugs which are slowing down the heart, normally because of the drug effect which he is already taking, there will be slowing down of the heart. That means the QT interval would already be a little more. This hydroxychloroquine will prolong this QT interval. Anything beyond 500 milliseconds may suddenly cause the heart to be dropped, but it can be heartbeat to be missed, but this effect can be reversed by stopping the drug. So a long QT interval is seen in hydroxychloroquine. Now there are certain impulses where electrolyte imbalance can take place. Now electrolyte imbalances means that normally there are electrolytes in the body, sodium, potassium and calcium. When you see these potassium, calcium levels, they have to be normally maintained. If there is either an increase or decrease in these electrolyte levels, it will cause a defect in the conduction defects, and that can be detected by an ECG. Say for example, if you find the potassium levels, the normal potassium level should be around 4.2 milliequivalents, but if you find that there is an increase in the potassium ions, or if there is a hyperkalemia happening, what will be the effects on the ECG? So hyperkalemia causes certain changes in the ECG, and those ECGs which can be seen there, the changes which can be seen there are, first the height of the T wave will be increased, the PR interval will be increased, the QT interval will be increased. So tomorrow on a patient, if you are seeing an ECG and the ECG says that there is an increase in the height of the T wave, the PR interval is prolonged, the QT interval is prolonged, you should suspect that is there any hyperkalemia or increase in the potassium levels. Similarly, hypokalemia. What does hypokalemia mean? Hypokalemia means low potassium levels. If it falls sufficiently low, you will find that the presence of U wave, a appearance of a U wave in a patient, you may have to suspect it to be hypokalemia. Similarly, sodium levels. Sodium levels are also very closely monitored in the body. An increase in the sodium levels, which means that the hyperantremia is happening. You will find that the ECG is very irregular. So whenever the sodium levels are increased more than normal levels in the ECF, the normal levels are 142 milliequivalents, increase of above 160 milliequivalents per liter is called as hypernatremia. If there is a hypernatremia, you will find that the ECG is totally irregular waves in the ECG. No synchronization of the waves are there, no synchronization in the patterns are there. So totally irregular ECG, which you should suspect it as a hypernatremia. On the other hand, if there is a decrease in the sodium levels and sodium levels are falling down, you will call it as hyponatremia. In hyponatremia, the only change you will find is that in all the leads, the voltage is reduced less than normal. If you find an ECG where in most of the leads, the voltages are reduced or the height of the wave is reduced, you suspect it to be a hyponatremia. Similarly, you will find that there is a change in the calcium levels. So if there is an increase in the serum calcium levels, you will find that there is an increase in the QRS complex. So you will find that whenever the calcium levels is increased, there will be a tall QRS complex. The height of the QRS complex will be reduced, will be increased. Whereas in hypocalcemia, where the calcium level is less, we know that calcium is responsible for the conduction of the impulses. Whenever you find that there is a decrease in the serum calcium levels or hypocalcemia or your tetany happening, you will find that all the intervals are prolonged. The PR interval will be prolonged, the QRS interval will be prolonged, the QT interval will also be prolonged. So this will be seen in hypocalcemia. So these are the changes whenever there is an electrolyte imbalance happening. Now myocardial infarction. Broadly at this stage there are many changes to be understood, many changes to be dealt with when you are dealing about the changes in a myocardial infarction. I will just give you briefly two things which will happen. In a myocardial infarction, if there is a elevation of the ST segment, with a T wave inversion, it indicates myocardial infarction. So what happens in myocardial ischemia, where there is no damage but temporary less supply of blood, coronary blood supply to the heart, you will find in a myocardial ischemia, you will find that there is a depression of the ST segment but the T wave is upright. So a depression of the ST segment with an upright T wave indicates myocardial ischemia. If there is an elevation of a ST segment with the inversion of T wave, it indicates myocardial infarction. Now this is another topic which you should see, premature contractions. What are premature contractions? Premature contractions are nothing but contractions which are taking place before they should occur. Hence it is called as premature contractions. There can be a premature contractions of the atria or they can be premature contractions of the ventricular, which is called as premature atrial contractions or which is premature ventricular contractions. This can be caused because of, apart from the conduction system of the heart, another system or some other point in the conducting system is irritating the heart and causing the impulse to be generated. I don't think you need to go into all details here. Just to see the ECG, this is a premature atrial contraction scene, a premature beat which is happening. See the gap which is there between, normally this is the PQRST, here there is a long gap, but here this gap is reduced. So there is a premature beat happening within the ECG record and that is called as a premature atrial contraction. So here it is a premature contraction there, which you can see that P wave is early and inverted at the AV junction. So this is a premature beat. Normally this is the gap between the two things. This is the P wave, QRS and the T wave, P, QRS and the T, P, QRS and the T. This wave is a premature beat. So if you find that there are certain such a premature beats in the heart, it indicates that there is a conduction defect. But normally also it is seen that some premature beats are present, but only if the number of premature beats is more than, let's say, 10 to 15 in a minute, then it becomes a cause of concern. About 4, 5, 6 premature beats are normal. Here this is the premature ventricular contraction. So this is the premature contraction. Here you can see that this is the QRS complex. After this, because if there is one more QRS complex happening before the normal rhythm, so this is called as a premature ventricular contraction or PVCs. This premature contractions, one of the things physiologically in a normal person, remember, can be seen because of excessive smoking, lack of sleep or coffee. So one of the commonest causes of premature contraction seen is either excessive smoking, excessive intake of beverages, especially coffee, and lack of sleep. Then we have got as an atrial paroxysmal tachycardia, where there is a tachycardia, means paroxysmal means series of rapid heartbeats, they suddenly start and they suddenly stop. This is atrial paroxysmal tachycardia. You will also have ventricular paroxysmal tachycardia. This can be normally ventricular paroxysmal tachycardia is seen after a myocardial ischemia or after a myocardial infarction. So with this, we will stop with the ECG. We have discussed the normal ECG, we have discussed the abnormal ECG, we have seen about how the ECGs are conducted. Thank you one and all. Please share or please give your feedback to my mail so that we can have a review of what needs to be done more so that your doubts are cleared. Thank you. From tomorrow, you will have some of our faculty who will be coming online and they will be discussing about the cardiac graphs, or they will be discussing the problems which are kept in the practical hall, or I may be coming again on Friday and we will discuss about the non-endocrine charts. I believe the endocrine charts were taken already earlier in the classes. Dr. Rajni had completed it. The non-endocrine charts we will see. Thank you.